2, 1. Please start, sir. We are live.
Yeah. Thank you. Thank you, team. So, very good evening, all respected doctors. I am Dr. Kunal Javeri from Zydus Medical Team. And once again, I welcome all of you for this newer topic discussion that is a BemTalk. So, as we know that the dyslipidemia is one of the major risk factor for development of overall cardiovascular disease. And we consider that LDL cholesterol is one of the bad cholesterol that definitely is on the top priority for the management of any kind of CVD prevention. But there are some data showing that even after using of maximally tolerated dose of statin, then 7 out of 10 approximately patients having uncontrolled LDLc. So we have fewer options available like PCSK9 inhibitors and ezetimibe. But recently in India, we have launched one of the very unique molecule, which is a Bempedoic acid, and which has shown a significant data in LDL reduction. So to elaborate about this therapy area and this molecule, we have a very senior interventional cardiologist, Dr. Subhash Chandra, who is from BLK Super Specialty Hospital from New Delhi, who has almost more than 25 years of vast experience. And for next 30-35 minutes, he's going to educate us or enlighten us about the uncontrolled LDLc and what is the role of Bempedoic acid in the therapy area. So without taking much ado, sir, I request to please start the scientific proceeding side. Thank you, sir.
Thank Mr. Javeri. So let me formally welcome you to this webinar, which is an educational effort from Zydus. And Zydus, as you know, is always in the forefront of academic pursuit. So in that line, another edition. So I'll be developing upon this topic of bempedoic acid in uncontrolled LDL cholesterol, unlocking the concept and unleashing the efficacy. So since this molecule is new in India, though it was approved by US FDA way back in 2020, as well as European guidelines, but it has researched or come in India just now. So let's understand what this molecule is all about. And I, being an interventional cardiologist who deals with the vast majority of atherosclerotic coronary artery disease, and I'm involved in their care in terms of doing primary angioplasties or reducing their MACE in future by using high dose of statins. So for me, cholesterol is the biggest culprit when it comes to coronary artery disease or any polyvascular disease. It is very evident in both primary as well as secondary outcome trials, where in this landmark trial by Dr. Salim Yusuf, that in primary prevention data, which was amassed way back in 2004, it was realized that out of the list of risk factors, which includes smoking, lack of exercise, or hypertension, diabetes, or obesity, or psychosocial factors, and the lipids just stand out because they are the biggest cause of progressive atherosclerosis. And therefore, the whole focus is on the LDL cholesterol reduction when it comes to primary or secondary prevention of coronary artery disease. This is a busy slide which highlights the primary prevention trials on statins, and namely some of them, which all of you are aware, are the CARDS, the FCAPS, and of course Jupiter. All these trials have clearly shown that there are definite number needed to treat by statins in terms of preventing the coronary artery disease as well as cerebrovascular accidents. Similarly, there's a plethora of data on the secondary prevention where high dose statins were used soon after acute myocardial infarction or acute coronary syndrome, like in PROVID-TIMI, where 80 milligram atorvastatin was loaded in these patients, versus a lot of other trials like Miracle or IDEAL and TNT, even Armida, where all acute myocardial infarction patients are loaded with atorvastatin high dose, and it results into a drastic reduction in major adverse cardiac events if these patients are capped on highest possible tolerated dose of statins for as long as possible. Now, the management of dyslipidemia is the top priority, and statins are the first-line therapy, but there are two challenges. The first is, do all statin users achieve the desired LDL cholesterol goal as per the guideline recommendation? And the second would be that what is the best way to reach there? And to reach the LDL cholesterol target, after maximally tolerated dose of statins has been exhausted, that is 80 milligram of atorvastatin or 40 milligram of rosuvastatin. So let's address these one by one. Concern one, it is clear that lower is better for longer. So lower the better and for as long as you can or your patient can tolerate. There is a plethora of data about the lowest possible levels of LDL achieved by use of various drugs, be it the surgical methods like LDL bypass or the use of high dose of statins or the PCSK9 inhibitor or addition of ezetimibe to statins, all of them in an endeavor to hit the LDL cholesterol levels to as low as 55 or even 40 in the highest risk category of coronary artery disease patients, where a patient soon after angioplasty has suffered a second or a third event within 2 years' time. So that is a subset, and various guidelines over last 5 or 6 years have been reducing these levels of LDL cholesterol desired to the lowest possible level. That would be soon after myocardial infarction should be less than 70. In cases of highest risk population, it should be less than 55. Even our own Lipid Association of India places it at 50. So that is what has to be achieved when it comes to the secondary prevention. If you compare these two guidelines between 16 and 19 in the European guidelines, you would realize that the targets have come down to 70 and 55 in very high risk category. So as the CV risk increases, need to reduce more LDL cholesterol and for the longest possible time. So based on these 19 guidelines, a very important observation was collected in the form of Da Vinci study, where close to 6,000 patients, both primary and secondary prevention, were studied. And what was glaring here is that the high intensity statin was only received by 27% of the eligible patients who were on lipid lowering therapies. And out of this, only 30% were able to achieve the target doses. Overall, if you look at between 16 and 19 comparison, when 19, in spite of using the highest possible dose of statin or the moderate or low dose of statin, because the targets were set higher, the number of population which is achieving targets were dropping down to 33 or 28 or 37 from the level of 2016 when it was still higher. So both the things have changed. The usage is not optimal and the targets have been pulled down, and therefore the whole controversy about not achieving the targets by using the desired statins. There is a clinical inertia also on part of physicians because of lack of awareness or because they are not convinced about data. And that is the whole aim of this exercise when we conduct a webinar on achieving the lowest possible dose of LDL cholesterol in the most eligible and vulnerable patient population. So in this data, 27% eligible patients were receiving high intensity statins, and 33% patients achieved lipid goal with this high intensity statin. That is the whole crux of this slide. Similarly, if you look at the very high risk population where the lipid values of less than 55 were desired, again, 37% eligible patients are receiving high intensity statin, and of which only 18% pathetically low were able to achieve the desired goal of highest intensity statin. So this is here where we are, and a lot needs to be done when it comes to the residual risk by virtue of having high LDL cholesterol in these population. So how much is clinically beneficial to achieve LDL cholesterol? This is another Korean study soon after acute myocardial infarction, that if patients were able to achieve a level of less than 70 after myocardial infarction, their MACE rates were significantly reduced compared to those who failed to achieve that LDL cholesterol by high dose statin. And it is evident that patients whose LDL cholesterol were less than 70, or there was a more than 50% reduction from the baseline, they had the lowest MACE rates. So it is imperative that patients after an acute coronary syndrome should try hard to achieve an LDL of less than 70, and high dose statin should continue, possibly lifelong. The second concern that how to achieve this target after maximally tolerated dose of statin has been exhausted. There are patients who were put on 80 mg of statin, and if you repeat their lipid profile after an acute coronary syndrome, you still find that their levels continue to be hovering at 80 or 90 or 100. or where they're desired to be less than 55 in very highest category, they still continue to be 70. So the philosophy is that you keep adding the non-statin alternatives, and that will be starting with the high dose statin where only 50% reduction is possible. If you add ezetimibe, you could still achieve another 15%. And if you use PCSK9 along with high dose statin, you could hit a target of 85 or 75%. But let me tell you that PCSK9 is not always affordable and it's not always tolerated well because of being injectable. So we got to find an alternative to achieve the target. And in that line, one drug by the name of Bempedoic Acid, which is a ATP citrate lyase inhibitor, which acts on the similar cholesterol pathway on which the statins act, but in a step ahead of it. I'll just take you through the journey that how does it happen. This drug was approved in US and European guidelines in 2020, and it was meant for reducing the maximally tolerated statin dose if LDL cholesterol is not achieved, or in mixed dyslipidemia, heterozygous familial hypercholesterolemia, or high-risk atherosclerotic cardiovascular disease. It was also meant for patients who are statin intolerant or where statins were contraindicated for some reason. And the drug needs to be given as 180 milligram orally with or without food dose. That's very convenient. If you look at this busy slide, you would realize that bempedoic acid is a prodrug which gets converted into active drug by ASCVL1 enzyme. And it is here that a step ahead of the statins where they act on HMG coreductase enzyme, the bempedoic acid is acting on ACL. And it inhibits the ACL, and thus it reduces the synthesis of cholesterol in liver. Besides this, it also upregulates the LDL cholesterol receptors, which are located on the surface of liver cells, and thus it achieves a much better lower level of LDL cholesterol, which was not possible by other molecules. Another important aspect of this drug is the drug is excreted in urine, and the drug is not metabolized or found in skeletal muscles. So this drug, unlike statins, is free from the myalgia or the muscle necrosis as it's evident from the high dose statins. So those two advantages exist with this drug, while it reduces the LDL cholesterol further over and above what LDL is reduced by the statins. A word of caution about this drug: as I told you, it excreted through the kidneys, so it could be safely given in both kidney and hepatic impairment patients. But in patients who have underlying high uric acid or have deranged renal functions, or patients who are elderly or taking corticosteroids or some kind of quinolones or renal failure or tendon rupture history, one needs to monitor this drug there, but one needs to discontinue this drug in patients who are elderly and have a history of taking steroids or the tendon rupture renal failure. This drug preferably should not be given in this population. But majority of patients largely accept it and tolerate it very well when it is added to high dose statins. Now, as scientists, we all look forward to evidence before we start prescribing this drug. So far, the evidence based on which the drug has got US FDA approval, there are 4 landmark trials by the name of Clear Serenity and Clear Tranquility. These were short-term trials, but these trials were conducted in a patient population who were statin naive or who have not received a statin, or they had side effects because of statin. And in this population, when the drug was given, the drug was able to achieve a significant reduction in LDL cholesterol value. There were 2 more trials, which are Clear Harmony and Clear Wisdom, where patients who were truly high risk or had familial hypercholesterolemia and other risk factors, when they were given this drug over and above highest possible dose of statin, the drug was nicely tolerated, and it could still hit back and bring down the LDL cholesterol by another 15 to 18% value. So these 4 landmark trials are there as phase 3 trials, and these are the results of these trials, that over a period of 52 weeks, there was a reduction in LDL cholesterol at the end of 12 weeks, which continued until 1 year, and the drug was overall safe in this population, as was seen here. Another important aspect of this drug was that even these are the results of Clear Tranquility and Clear Serenity, which was done in patients with hypercholesterolemia or statin intolerant patients. And there also, there was an LDL cholesterol reduction by merely using this drug and not statin in this population. This is the data of Tranquility and Serenity, with LDL cholesterol is reduced to the tune of 23%. In addition to ezetimibe also, the drug has been tried, and even there, the reduction in LDL cholesterol is much more significant than what it was in the monotherapy or in isolation. There is some data on the high sensitivity high sensitivity CRPs, which is an inflammatory marker, which is also reduced by the use of drug. Now, as scientists, we look for the outcome data for any drug before we start embracing it completely. And that is what is missing so far, but it is in pipeline, and very soon we'll be getting a proof where the bempedoic acid has been used in this clear outcome trial. The recruitment is going to finish sometime late this year, and in soon 1 or 2 years time, the results of bempedoic acid versus placebo would be available, where an reduction of MACE could be demonstrated by use of this drug. Till that time, suffice to say that any drug which could bring down LDL cholesterol to desired level is welcome, and as long as it is well tolerated in our population. And it is imperative and logical to see that lower the LDL cholesterol, better it is in terms of MACE or mortality reduction or longevity of this patient population. So we'll wait with bated breath for this clear outcome data, and it is a huge data on 14,000 patients. And we definitely hope and be optimistic that this outcome trial, like the ezetimibe data in the recent trial, which has shown outcome data, would be on the similar trend as was seen with bempedoic acid. So it does reduce inflammatory markers, I told you, and the data says that hsCRP is reduced from baseline by the use of this drug. So I have a lot of optimism that this drug should work for MACE reduction also, besides LDL cholesterol reduction. Now, a word about the adverse events. There are only 2 adverse events on which we are worried about: the hyperuricemia and the gout. And this was significantly higher in the bempedoic arm than the placebo. So in this patient population, or patients who have a history of tendon rupture earlier, one needs to be cautious and careful that one has to be looking for hyperuricemia or precipitating gout in this population. So if I may summarize what I've discussed in last 20 minutes, is that uncontrolled LDL cholesterol is a major risk factor for cardiovascular disease. Statin is the first drug of choice for therapy of this dyslipidemia. And even after high intensity statin, if 70% patients have uncontrolled LDL cholesterol, the increase is a risk of severe risk by 60% to 70% by this phenomena. And bempedoic acid is the first in class drug which have unique mechanism of action at ACL inhibitor and LDL receptor upregulation. So there's a significant LDL cholesterol reduction up to 18% from baseline as an adjuvant to statins, and is safe in mild to moderate CKD patients. But hyperuricemia and gout are common adverse events and which should be monitored on a regular basis. So I hope I'm able to convince you and apprise you and update you about the available data on this drug. And I have also left the forum open for discussion with that clear outcome data, which should be available to us in coming years or 2 years' time. Thank you very much for your attention, and I close my presentation here. And we'll be glad to answer your questions.
So thank you, sir. It was a wonderful session, and very nicely, sir, you elaborated that yes, management of uncontrolled LDLs is very important, and the bempedoic acid is definitely a good hope, and with a very positive data that definitely will be helpful for the patients. So we have some 2 or 3 questions from the audiences. The first question is regarding the efficacy part of the drug. That the question is on that this drug is adding approximately 15 to 20% of LDLc reduction. Then what should be the ideal patient profile that after statin that we should use this drug in such kind of patient for the primary or secondary prevention?
So currently my take would be that in the eligible population, like post-ACS or progressive atherosclerosis, if your aim is to achieve an LDL value of less than 70, and you have done your bit by adding highest tolerated dose of statins, that is 80 mg of atorvastatin or 40 mg of rosuvastatin, you're not able to achieve that level by giving a monotherapy of statin, you could choose between ezetimibe or bempedoic acid. Both the drugs are available to us. Given the adverse effect profile and tolerability of bempedoic acid, that could be the first drug to be added there. Or one can go through the route of adding ezetimibe first, reviewing the lipid profile then, and if that doesn't work, then you add this as the third drug, bempedoic acid. But the aim remains that you got to bring down LDL cholesterol below 70 or even below 55 in patients who are very high risk profile by virtue of having a second ACS event within the first or second year of the angioplasty or bypass surgery.
Okay.
So I would use it in that vein.
Okay, sir. So the second question is that, as you have mentioned, this drug is least active in skeletal muscle. So would it be a good alternative when patient having the statin-induced muscle side effects or muscle toxicity?
Very, very good suggestion. So as you know, we often come across the myalgia or muscle ache in our patients, and we try various maneuvers ranging from changing it to some other statins like pitavastatin or something else, or reducing the dose, which is not the right way of doing it, because then you compromise on LDL cholesterol values. So in that category, this drug can clearly emerge, as was seen in the Serenity and Tranquility data, that this drug could really help you bring down LDL cholesterol values up to 20% of what you desire. So the drug has a niche place in that category also, where patients are intolerant to statins.
Okay. And last one about the algorithm, what the one doctor is asking, that though this drug is has not severe outcome and it is mentioned by all the guidelines, but still not mentioned in algorithm. So how much it is useful in our Indian population? Still, it's not in the guidelines.
As you see, as was the case with ezetimibe earlier, you would recollect the history of ezetimibe, how it evolved. In the beginning, when ezetimibe was being used to reduce LDL cholesterol and was not adding up to any MACE outcomes, that the drug had to wait until the Improve It trial came, and that clearly shown in NEJM journal that by adding ezetimibe, you're actually reducing the MACE further over and above what you achieved by giving LDL. So then ezetimibe became a part of the guidelines. I see similar fate for bempedoic acid in coming times, that this should be incorporated in most of the guidelines if you wish to achieve LDL cholesterol to the desired level.
Sure. So I think there are some questions we already, sir, we have discussed in one another way. So with this, I think, sir, we would like to end the session here. And thanks a lot for your, once again, for your very excellent elaboration about the dyslipidemia, uncontrolled LDLc, as well as the bempedoic acid. So definitely it's helpful for us and as well as those who attended this session. So thank you, sir. Thanks a lot. Good evening.
I tried my best to give a very balanced picture of this molecule.
Yeah, definitely, sir. It was very fantastic.
Thank you so
Definitely.
much. Bye-bye.
Thank you, sir.